deciding whether the patient, how old the patient is, if that hasn't been given to you in the history. So seeing whether they're skeletally mature or immature can sometimes be very helpful, particularly when thinking about certain conditions. And then looking at the lesion in question. So you've found the lesion, which bone is it in, which part is it in the epiphysis, metaphysis, diaphysis? Interrogating the lesion, is it well-defined, ill-defined? What is the internal matrix like? Is it predominantly lucent, sclerotic? And then trying in your mind, when assessing that lesion, to decide whether the lesion is aggressive or non-aggressive. So there are certain things that we can look for, and the first is periosteal reaction. And not all periosteal reaction is aggressive per se. When a lesion grows rapidly, you're having interrupted growth, so you're having more aggressive type periosteal reactions, such as hair on end, spiculated, that lamellated or onion skinning type of periosteal reaction. Whereas when something is either slowly growing or healing, so for example, in a fracture, if you have a fracture healing, that can be nice and smooth and solid and continuous, which is non-aggressive. And then looking at the cortex, and the image on the slide is a nice example where possibly at the ulnar border of that distal radial metaphysis looks fairly ill-defined, and you'd be raising the question of whether there is cortical destruction at that margin. And then predominantly you'll be shown plain films, and you'll be looking for distortion of the adjacent soft tissue planes and trying to get some more information of whether there's an associated soft tissue mass. And yeah, pathological fracture is pretty self-explanatory. So nice summary here of some of the conditions that we will be looking at today. So it's a nice table, and I have to specifically say thank you to Sam, who has actually written the majority of these slides today. This is a lovely table here. So nice age discriminating factor. So under the age of 20, aggressive lesions. So if any of your cases do appear to be an aggressive lesion, you've got your differentials, non-aggressive and lytic. And I'm sure you all know of that A, B, C, D, E, F. So you've got the nice mnemonic there to help you think of your differentials, and then some examples of non-aggressive and blastic conditions there. Right, so if I could have candidate 1 to have a little go at describing the first case.
Okay, this is a frontal radiograph of left upper limb, humerus, and the left shoulder joint. I see there is in the proximal of the left humerus, there is bony lesion showing a lucent bony lesion with well-defined sclerotic margin. In this view, I suggesting this is projecting from the bone. It is narrow zone of transition. I need another orthogonal view to more visualize the other view for the bone. In the other view, however, in the right side, not clearly it's masked by the scapula. However, I am going with non-aggressive bony lesion, as I see narrow zone of transition, and the cortex appear to me be intact. So, for me, I think this is could be non-aggressive bony lesion, Osteochondroma, the first possibility for me.
Excellent. I'm sorry, I didn't catch your name. What was your name?
Candidate 1.
Candidate 1, lovely. Okay, so that was a really nice description, excellent description. I like that you ended on whether you felt the lesion was non-aggressive or aggressive. If this plain film landed in your reporting pile, would you be, with the clinical information given that this patient has pain, would you be suggesting anything?
If the patient has pain, I suggesting there is a malignancy change of Osteochondroma. I will review if this patient has MRI before. to see the cartilage cap thickness. If this is more than 1.5 centimeter, we will going with chondrosarcoma transformation of osteochondroma. I was also to rule out soft tissue change for this advanced for the patient from osteochondroma benign to the chondrosarcoma.
Okay, great. So if I show you the MR here, and you correctly identified this as an osteochondroma, you can see that medullary continuity within the lesion. You talked a little bit about the cartilage cap, and yeah, you're right. So you're looking for anything over about 1.5 centimeters in adults. It varies in children. I think it's more of a clinical, you'd be guided a little bit clinically. Is there anything that you wanted to mention on the MR?
MR in the this T1 sagittal view, I see it is this is a bone. Sequence of cartilage cap is for me in my T1 sequence. It is continuous, no measurement in the set of the image. In the stair view, I see some high signal.
Yeah.
Some high signal in the sketches of the bony lesion, other than the cap. For this one. So I think this could be cause of the pain for the patient. Until for me now, I didn't have the measurement clear for me. So I'm keeping with the Enchondroma as no soft tissue.
Yeah, good. Sorry, it was breaking up just towards the end, but yeah, so Osteochondroma, I know that you can't measure it, but it's not more than 1.5 centimeter. So just a little summary about osteochondromas. You can get many different types, but usually you want to see that corticomedullary continuity with the kind of, as described inside, parent bone. When you're looking at the cross-sectional imaging, it's really important to assess for any mechanical complications. So if someone is presenting with pain, it may be that the osteochondroma is compromising, say, an adjacent neurovascular structure. And as candidate 1 correctly identified, that you would want to look at the cartilage cap and any marrow abnormalities. So there are kind of other associations when you have multiple osteochondroma. It's known as multiple hereditary exostoses. And here's a lovely example of a patient with we can see lots of different types, so broad-based, sessile, pedunculated osteochondromata throughout their limbs. This is an autosomal dominant condition, and again, you would be assessing clinically for any pain or mass enlargement. I think that there's a very low incidence of transformation, around 1 to 2% to chondrosarcoma. Candidate 2.
Yeah.
You'd like to have a go at the second case?
Yeah, so I'm given with the frontal and radiograph of the right hand of a skeletally immature patient and corresponding lateral image of the middle digit. So I can see that there's a well-defined latex lesion in the proximal phalanx of the third digit, causing bony expansion and cortical thinning. And I can appreciate some thin, incomplete septations within. However, there is no periosteal reaction. Overlying soft tissue shows swelling. It has not involved any of the joint proximally, and no other lesions are seen in any other bone. So can I know what has the patient presented with, the history for the patient?
They had trauma playing netball and they had some pain in their ring finger.
So based on the presentation and the age of the patient and the location of the lesion, my first differential would be Enchondroma, and I have never seen ABC here, but it could be a simple bone cyst. Yeah, the lesion is more of epimetaphyseal. Yeah.
And
So,
would you be saying this is aggressive, non-aggressive? Would you be suggesting anything else?
So it is a lytic lesion, and since there's no peritoneal reaction, soft tissue or anything on the particular radiograph, I won't be able to comment. I would suggest a cross-sectional imaging, particularly an MR of the lesion, to comment upon it.
You would suggest, I'm really sorry, you keep cutting out.
Yeah, a cross-sectional MR, yeah, to comment upon its aggressiveness and in further involvement of other structures.
Okay. So I would agree doing an MR would be helpful if the patient were having symptoms. Enchondromas are fairly common. I wouldn't suggest doing an MR for every enchondroma that you see. But that was really well presented, really nice. You would hope that if you were to be given an exam case like this, that a case would have that very typical ring and arc chondroid matrix. I've given you a bit of a tricky one, but you handled that really nicely. And here you can see it's central diaphyseal that usually expands our lesions, and you can see that nice thinning of the cortex and kind of endosteal scalloping that occurs with these lesions, most commonly in the hands and feet. And you can get pathological fracture, so I was pleased that you were looking at the cortex and looking for some periosteal reactions. So again, a nice summary slide here for you all. They're benign tumours, and a peak age is 10 to 30 years. So half occur in the hands and feet. And that is pretty much the most common place, I would say, you see them, but you can see them in the proximal humerus, proximal femur, and there's a very low incidence of them transforming to chondrosarcoma, but you have to be looking for those, as candidate 2 was for that periosteal reaction. When you see enchondroma and you see more than one, multiple ones, for example, in this case, you start to think about Ollier's disease. Now, this is a non-hereditary abnormality, and you can see here where, we have lovely examples of multiple enchondromas, and the difference in this case is the risk of transformation into a chondrosarcoma does jump up to around 25%. Very similar appearances to the others that we saw previously. And another consideration is Maffucci syndrome, and this is when you have multiple enchondroma with multiple soft tissue hemangiomas. So you may see unilateral involvement of hands and feet. Now, the malignant transformation is much more common than in Ollier's, and you can see this is a really nice hand X-ray showing multiple enchondromata with soft tissue abnormalities. So you've got then increased density and almost phleboliths in some of the soft tissues, pointing out those soft tissue hemangiomas. Okay, back to candidate 1.
Okay, sorry. This is an EV radiograph of knee joint of immature children. I see there is lytic lesion in the proximal metaphysis of tibia, exenteric. There is narrow of transition. There is cortical not clear for me. I think no cortical creaching, no soft tissue swelling. There is no matrix classification. The upper end adjacent to the epiphysis, not reaching the articular surface. It's limited by the epiphyseal plate. There is, I think, this fine internal septation, and the one set of the image of T2 stair for the concerned lesion, showing multiple air fluid level with high signal and low signal alternating. This is going with aneurysmal bone cyst, more likely. The other differential is not here. It telangiectatic osteosarcoma. However, this is a lesion concerned more with the bone expansion and do not has pre-ossea reaction. It is non-aggressive bony lesion. It is aneurysmal bone cyst.
Excellent. Really nice description and summary. You've pretty much stolen everything on my next slide, so well done. So yeah, this is an aneurysmal bone cyst. They're usually lytic, expanded, eccentric, tend to occur within the metaphysis, but can expand into the soft tissues. And you can see on the axial image here, we have a trace of periosseous edema. They tend to be well-defined, thin sclerotic margins, and see the characteristic fluid levels as demonstrated on this axial image. I was actually always taught by one of my consultants that ABCs tend to occur in the presence of another lesion. They rarely occur on their own, so you'd be really looking for and interrogating to ensure that there isn't another or underlying tumor along with that ABC. Predominantly these occur under 20, and we've seen a lovely example and description by candidate 1, who also mentioned the telangiectatic osteosarcoma. So an example here. So when trying to differentiate between the ABC and the telangiectatic osteosarcoma, so we've got the ABC at the top left, and the telangiectatic osteosarcoma on the right-hand side. And you can see how ill-defined those margins are. So the arrows are pointing to the sacrum, whereas on the left with the ABC, it's far more well-defined. And also the infiltrative kind of process around the lesion for the telangiectatic osteosarcoma. So looking for those more aggressive features for the latter. Okay, candidate 2.
Yeah, so I'm given with the frontal and lateral radiograph of the left arm, including the shoulder joint and part of elbow joint. So I can see well-defined expansile lytic lesion in the proximal metaphysis of the humerus, which has got a few septations within, causing endosteal scalloping and a wide zone of transition. Okay, so there's no significant periosteal reaction. The overlying soft tissue is well. The joints and other bones appear normal to me. Okay, so the differentials on this would be, since it appears to me as a groundglass matrix, so I would say put fibrous dysplasia on top and later ABC. Yeah.
Again, I'm really sorry, you cut out. What was your top diagnosis?
Fibrous dysplasia.
Okay. And what other things occur in children in this location?
Aneurysmal bone cyst, ABC.
Okay, so we've just seen an aneurysmal bone cyst, and they tend to be eccentric, so this is fairly central.
Yeah.
And predominantly within the diaphysis, extending into the metaphysis, proximally, I guess, but it's predominantly within the diaphysis. So again, any other ideas? If this is in your A&E emergency department plain film reporting pile and patient presents with a fall, what would you be suggesting? Would you be suggesting anything?
I would further take up the patient for cross-sectional imaging.
Okay. Can you think of any other conditions that occur? in this region? Don't worry if not. If I show you in MR.
Yeah. So the PDF is image. No. Yes, the PDF's image shows the lesion to be showing me the blood fluid levels and is hyperintense on T1. And again, there's layering in the actual PD fat set images. So, could it be? I'm not sure. Could it be a brown tumor?
Okay.
But it's showing me the fluid levels. So my differential of bone cyst is on the top. Simple bone cyst.
Okay, simple bone cyst.
Mm-hmm.
Okay, good. Okay, so I think this is a tricky case. You tackled that really nicely. The key features are, I guess it's intramedullary. The one that I've shown you has actually fractured before, which is why you're seeing on the plain film.
Yeah, the lateral cortex.
You can see that it's fractured before within the proximal part of the lesion. And that's why I think it gives that kind of fibrous dysplasia appearance. But most importantly, in a child of this age, in this location, with some of those characteristic findings of a unicameral or simple bone cyst. Now, the layering actually suggests that they've had a previous fracture. The plain film and the MR don't show an acute fracture, but that layering within the lesion nicely picked up by candidate 2 from the axial imaging, particularly, you can see that there has obviously been some hemorrhage within that. So a nice summary slide here. Again, these are benign lesions. They can look complex, particularly if they've had previous trauma and fracture. 85% occur in the first 2 decades, and usually they do spontaneously resolve. Some of them do require treatment, and they decompress them, bone graft them, particularly if they've had fracture. Very, very common site. So in the proximal humerus, at least 50%, and 25% in the proximal femur. So as the child grows, they tend to move away from the physis. So you can see there's a fairly long lesion. And someone has also mentioned in the chat, you get that pathognomonic fallen fragment sign when they do have a pathological fracture through the lesion. Candidate 1.
Okay. This is an EP and the lateral radiograph of the left knee. There is a lytic lesion in the proximal metaphysis and extending to the epiphysis of the tibia. The lesion is showing partially in the lower part, narrow zone of transition. There is also a fine trabeculation inside. This is extending to the articular surface. In this mature bone, I will going with giant cell tumor. I don't see any fracture of surrounding cortices. I don't see any soft tissue mass. So this is a giant cell tumor for the patient.
Okay, good. Can you talk to me a little bit? You said narrow zone of transition. Can you talk to me a little bit about the lateral border of the lateral margin of the lesion?
The lateral margin of the lesion is not sclerotic. There is no sclerosis surrounding it. However, I see partially sharp or partially irregular. It's defined partially. So this is confusing to be as narrow zone of transition here in the lower border of the lesion.
Okay.
Here.
And what do you think about the cortex of the medial proximal tibia?
The medial proximal tibia. In the EP view, I don't see cortical breaching. Not clear cortical breaching here. No, I think there is some, but it's not definitive process reaction. It's not clear for me.
Okay.
But however, in comparing the medial aspect of the lesion of the cortex in comparing to the lateral part, lateral cortex of the tibia, I think it is there is a thinning. Could be there is some thinning of the cortices in the middle aspect here. compared to the left side, lateral
Right.
aspect.
So do you think this is aggressive or non-aggressive?
For this affection of the medial cortex, I think we're going with aggressive bony lesion.
I'm sorry, you cut out. Aggressive or non-aggressive?
Aggressive. I think we'll go with
Okay.
aggressive.
Okay, what in particular are the features that you're citing for it being an aggressive lesion?
Aggressive bony lesion, usually I have a wide zone of transition. I usually have Brose reaction, marked Brose reaction. I see if there's soft tissue mass or swelling considered for the pathology.
No, so in this case, what features are you seeing that makes you think this is an aggressive lesion?
It's worry for me is a medial aspect of this lesion. However, it's not clear. It's not clear to be.
Okay. Okay. Well done. This is a GCT. So I think this is a really nice example. It's lucent. They don't tend to have sclerotic margins. So actually, that's a nice discriminator. So it's a lucent lesion with no sclerotic margin. They tend to predominantly occur when the in skeletally mature. So when we were talking about the previous case of the unicameral or simple bone cyst, you know, that was a pediatric case with open physes. You don't tend to see GCTs in skeletally immature patients. Now, the candidate one correctly identified there is some thinning, but actually there's some periosteal reaction along that medial border of the proximal tibial metaphysis, which is slightly concerning. So the GCT itself can be locally aggressive, and it's important to look for some of those aggressive features. 75 to 90% occur in the long bones, predominantly in older people, so 30 to 50, and they originate in the metaphysis and extend to the epiphysis and often abut the subarticular bone. They are generally eccentric with no sclerotic margin, and are, you know, the words narrow zone of transition. I found using zone of transition a little bit confusing. I prefer describing lesions as well-defined or ill-defined, but I understand that's a personal preference. So they tend to be well-defined, and you very rarely tend to see them as lobulated or bubbly lesions, and they are associated with some genetic syndromes as suggested at the bottom of the slide. Differentials, as you can see on this slide, for GCT is chondromyxoid fibroma, but as you can see in this slide, an example, you can see that sclerotic margin, and it appears a little bit more lobulated than the previous example of the GCT. There's a little bit more of a wider range, age range. So you tend to see these predominantly within the second decade of life. And here you can see a geographic lesion, a lobulated lesion with a sclerotic margin. They tend to be eccentric and expansile, but you don't tend to see that chondroid matrix. The name is a little bit of a misnomer, actually, so they tend to be predominantly lucent with that lobulated, bubbly appearance. I think this is candidate 2.
Yeah.
Yeah.
So, given with the lateral and frontal radiograph of the skeletal knee joint and proximal leg, full leg in lateral view of an skeletally immature patient, and okay. I see multiple well-defined reticulocencies in the proximal metadiaphyseal region of the tibia, and with sclerotic margins. The cortex is normal. There's no periosteal reaction, and the tibial epiphysis appears to me a bit ballooned up on the also the also the medial femoral epiphysis.
Sorry, what's ballooned? I missed that.
The tibiofemoral on the medial aspect, the epiphysis appears a bit. There is an asymmetry between the lateral and medial femoral and tibial epiphysis. And I can see some lucences in the frontal radiograph on the fibular lateral aspect of the mid-tibial diaphysis.
The recording has stopped. This meeting is being recorded.
The lesion shows sclerosis, well-defined sclerosis in the frontal radiograph. So this is a mixed sclerotic lytic lesion in the mid-diaphyseal, metadiaphyseal region of the tibia, with some asymmetry in the knee joint and bowing of the frontal bowing of the tibia. So if it is, does the patient under fever, so I would put my infective etiology as the first differential. And
Did you say infection?
Brody's abscess.
Okay.
Or
is this a typical location for infection?
No, it is not. And
where would you tend to see infection or Brody's abscess?
Why did I say Brody's? It would be more of tibial metaphyseal, distal tibial metaphyseal or proximally. Could it be? Cannot think of a mixed sclerotic lytic lesion in an skeletally immature patient and child.
So don't worry about what the diagnosis is. Okay, I just don't worry if you don't know what this is. I'm not concerned by that. I'd like you to concentrate on whether you think this is aggressive or non-aggressive.
So it has caused a bowing of the tibia. Had the patient inherit the skeletally deformed bone, I would say the lesion is non-aggressive because I cannot see any periosteal reaction, soft tissue swelling, or
okay.
There's a narrow zone of transition. I can see the inferior lateral borders, the inferior medial borders,
Yeah.
superior borders. Yeah.
Yeah. Good. Okay. So you're not seeing any aggressive features. You don't know what it is, and that's okay. That feels uncomfortable, but that's okay. You're trying to develop a safe framework. So when are you worried and when are you not worried? You're not really worried. You can see that there's bony deformity, there's bowing of that tibia. And actually, if you look really hard at the anterior cortex on the lateral view, can you see anything along the anterior cortex?
Yeah, I see a lucency. So I was worried whether there's a fracture because of the sort of torus or something buckling sort of.
Okay.
Yeah, lucency. And also I can appreciate some, maybe it is an overcalling in the distal tibial epiphysis. I could see a thin linear lucency.
Okay. So we're thinking that the patient may have had a previous fracture.
Mm-hmm.
Does the MRI help you at all?
Yeah, so now the lesion has overgrown its origin and extended a bit into the soft tissue with an exophytic component, and it's T1 hypo and mixed intensity on T2. With subtle edema on the medial, but I can see the lateral cortex to the fibula. I can see it well defined, but the medial cortex is encroached and destroyed. And
so actually, do you mind if I stop you? Is that okay? Actually, the cortex is thickened. You have what looks like endoskeletons.
Sorry.
Yeah, no,
yeah, T1, I can see the cortex well defined. It is basically growing into the cortex. So Osteoblastoma would be my differential now.
Sorry, what was that?
Osteoblastoma, but it's not a typical location for it. Is it a diphyseal and cortical osteoidostoma?
Okay,
Yeah.
so there are a few things that you can get in the tibia, and they're tricky. So in a pediatric population, we're thinking about osteofibrous dysplasia, fibrous dysplasia. This is a nice example of osteofibrous dysplasia. It has that mixed density. You have that nice sclerotic margin with a slightly fibrous component internally. There's no real aggressive features that the patient did have previously, a pathological fracture. And we could see that nicely in candidate 2. It described that really nicely, where there was thickening and a linear lucency within the anterior cortex. Around 50% of these occur under the age of 5. They tend to occur within the diaphysis. And you do have that nice sclerotic margin generally. It's very difficult to differentiate osteofibrous dysplasia from an adamantoma, but the age does help to be a discriminator in those cases. These tend to go down to the bone tumor centres and have biopsies, but there's nothing really that aggressive on the plain film. It was really trying to see that evidence of the previous fracture and trying to link that maybe the pain may be coming from that. Candidate 1, on the same theme.
Okay, I see this is an radiograph of the femur. I see there is a wide expansion of the intertrochanteric region and the proximal shaft of the femur. There is a ground glass delicia of the medullary cavity with expansion. There is no cortical breaching. The upper end showing clear edge of the pathology. The lower edge is continuous, not ill-defined, no soft tissue mass. I will going with in this region. I will going with fibrous dysplasia, more likely for me. Also in this region, also what's called here is the specific lesion here is one of the fibrous lesion coming in this region. It is not aggressive lesion. This is benign one.
Good. Okay, excellent. So yeah, this is a nice example of fibrous dysplasia. They usually are, they can be mildly expansile, and you get that nice kind of ground glass, that smudged appearance internally, which is that matrix, that fibrous matrix. It tends to be poorly organized. You're seeing this kind of smudged appearance. It can occur as a monostotic pathology or polyostotic, and there are multiple syndromes associated with those, which I'm sure you've all heard about: McKeown-Boyce, Mazabrad, and you can get associated limb length discrepancies. Really nice example on the plain film, nicely described by candidate 1. And you can get the associated bone deformities, so that varus femoral neck, which is otherwise known as the shepherd's crook. A kind of good note just to put in here is, so the first image shows a nice example of the shepherd's crook deformity. The second image shows a lesion which I'd like you to be aware of. It's a used to be called a lipo. Oh, sorry.
Okay. Sorry. Cytoma.
So the lesion on the right used to be called a liposclerosing myxofibrous tumor. It's now thought to be on the spectrum of fibrous dysplasia. So it's just to be aware that those lesions tend to occur in the intertrochanteric or femoral neck lesion, and you can see that densely sclerotic focus centrally. And they tend to be a little bit more well-defined with a sclerotic margin. You can see the differences with the two images side by side there. Candidate 2?
Yeah. So I'm given with the frontal and lateral radiograph of right ankle joint of a skeletally immature patient with foot seen. I can see well-defined eccentric cortical-based lytic lesion in the lateral distal cortex of tibia, and with well-defined sclerotic medial margins, narrow zone of transition, no periosteal reaction, and some deficient cortex on the superior part. No soft tissue swelling, and no other lesion. So based on the appearance and location, my differential would be osteoid osteoma.
Okay, can I ask you just to tell me if you think this is aggressive or non-aggressive first?
It has caused a bit deficiency in the cortex, but based on the location appearance, I would still designate it as non-aggressive.
Good. Okay, so non-aggressive. Tell me what you know about an osteoid osteoma. Why do you think this is an osteoid osteoma?
It's based on the cortical location, but it's not that diaphyseal. Yeah, my second differential would be a non-ossifying fibroma.
Okay.
8, yeah.
Okay, good. So we'll come on to osteoid osteomas later. But you nicely described the non-ossifying fibroma in this distal tibial metastasis. They tend to be long lesions, eccentrically placed. And this is a nice example of what's described as a bubbly lucent lesion. They tend to have that sclerotic margin. There's no periosteal reaction or really aggressive features associated with the lesion, as you really well described. When you follow these up, or when you incidentally follow these up, they tend to become a little bit more sclerotic until they completely remodel to normal bone. They are also known as Fibroxanthoma, fibrous cortical defects. They're all on a spectrum of the same process. They're benign fibrous lesions. Really, the differentiator here is how large the lesion is, and that really decides what you call it. But a nice example, well described. These can be associated with neurofibromatosis type 1 and Jaffe-Campanachi syndrome. So just to have that in the back of your mind when you see multiple non-ossifying fibroma. I think we're on candidate 1.
Okay. Okay. This is a frontal radiograph of the knee, left knee, and AB and lateral radiograph. And following the cortices of this immature skeleton, I see following the cortices of the femur. I see the cortice is continuous, complete, and following the tibia and fibula. The most worrying for me is there is in the right medial condyle of the femur, there is a rounded lucent lesion in the right femoral medial condyle with thin sclerotic margin. It is well defined. I see some soft tissue swelling. However, I don't see any evidence of effusion in the concerned joint space. I am worried about, for this young age, I'm worried about infectious pathology. This could be a broad abscess. I need to do MRI for more delineation and delineation and characterization for this pathology.
Good. And any other differentials that you know of lucent lesions that occur in the epiphysis that you would include in your differential?
Other differential for lucent lesion in the epiphysis could be this what's called the Chondroblastoma for this region in the immature skeleton.
Excellent. Yeah, excellent. Well done. Nice description and really good differential, like sensible differential there. So this is a chondroblastoma. They tend to be tumors arising within the epiphysis of skeletally immature patients, and they generally affect the age group between 10 and 25. They tend to be really well-defined lucent lesions with thin sclerotic margins. And the differential really to be aware of here is the clear cell chondrosarcoma. It's a very rare low-grade variant of a chondrosarcoma. It also arises within the epiphyses, and really it's only the kind of discriminator here is age. And this is just to show you an example of what that would look like. So the plain film, you can see that fairly similar lesion really. If you have an AP radiograph, this patient is 35, and you can see that well-defined lytic lesion with the sclerotic margins, just as we did in the case before. And actually this lesion was picked up incidentally. The non-contrast CT in the top corner has an arrow pointed to the punctate calcification, which is the internal matrix of the lesion. It's really well-defined. You can see that surrounding sclerosis. And then the MRI images at the bottom, just once again showing that this is a really well-defined lesion with a thin sclerotic rim. And this was proven to be a clear cell chondrosarcoma. Candidate 2.
So I'm given with a frontal radiograph of the pelvis of a skeletally immature patient with a gonadal shield on. I can see a fairly defined sclerosis in the right proximal metadiaphyseal region of the eccentric cortex, and some lucency in the neck of right femur towards the trochanter. So this cortical based sclerosis with some internal lucency points towards the first differential of osteoid osteoma.
Okay, good.
The lucency, I'm not sure whether I'm overcalling or is it a lesion in the femoral neck.
I suspect, are you talking near the greater trochanter?
Yeah.
Yeah, I think that's projectional. So tell me, what would you expect to see on the MRI?
So and this lesion would show me the nidus, the sclerosis lesion, and the MR.
So that is what you're looking for. But what would be
more it would manifest, more it would be seen to me as an edema of the bone.
good? Okay, so you tend to see on the MR the reaction, right? You tend to see diffuse marrow edema. Which modality would clearly show you the nidus?
Bone. So for nidus, it would be CT.
Okay, good. So here you can see a nice example of that cortical thickening, the surrounding sclerosis, and the central nidus in the middle of that. So really well identified on the plain film. And you can see how this looks very different to the non-ossifying fibroma that you described before, candidate 2, yeah?
Mm-hmm.
So this is a bone-forming tumour. You tend to get that really thickened cortex and that adjacent sclerosis that we're seeing nicely on the CT and the plain film here. Whereas in that non-ossifying fibroma that you described, that cortex was really thin and it was really well defined, and you can see how ill-defined the osteoid osteoma looks in comparison. I hope that's helpful.
Mm-hmm.
Okay, summary slide. So we've already talked a little bit about it. The helpful information, if you can ask, is whether they have night pain, which is helped by non-steroidal analgesia, and these can occur anywhere. And we've got some great examples of them occurring kind of within the medullary cavity and intra-articular. These can occur everywhere. So in a case of a patient with pain, diffuse merit edema, there should be up there with infection as a cause. You tend to see that nice lucent nidus, which can have central sclerosis within it. And again, if you're lucky, if the nidus tends to be small, so you don't always actually see it on the MR. The CT is really the clincher here, particularly in that case. And I'll just show you a couple of additional examples here of an osteoid osteoma. And you can see on the axial imaging, the last image here, how thick that reaction and that sclerosis is, where that nidus is sitting, and that kind of reaction that it's caused. Move along. So I think it's candidate 1.
Okay. This is an MRI in axial cuts of the brain. In the first one, the left side, this is the one submitted image. I see there is right frontal midline extra-axial hypo-intense well-defined mass. I think it is in T2, it is showing high signal with internal low signal. And I think this is the right side contrast study showing well-defined, well-enhanced margin with low signal in the middle.
Good.
This demonstrated is this okay. Okay.
I'll give you some more.
Okay. In bone window axial cuts, this lesion frontal showing beveled edge with narrow lumen of the internal diplo and soft tissue component sequestrum in front of it, as demonstrating in the 3 volume rendering, and in soft tissue here in the sagittal view, showing enhancement of peripheral enhancement of the margin of this pathology. I think this is eosinophilic granuloma lesion in this age group, and this is pattern of bone appearance in the bone. This is eosinophilic granuloma.
Lovely description, and I mean, I think those are quite tricky on the MR, to be given the MR to start with. It is part of a spectrum of histiocytic disorders, and you have lots that includes. So these can present with either a single lesion or multiple lesions, and the CT is a really nice example, particularly with that 3D recon of seeing that skull lesion with that beveled edge. Most commonly, I guess, in exams, you tend to be shown a child with a spinal film or imaging with a vertebra plana, very commonly. So again, this is another example of how aggressive and how different it can look in different bones. This is thought to be an aggressive lesion, quite rightly so. You can see it's very ill-defined. It's causing remodeling of that bone. The child went on to have an MR. I'm not sure the MR really helped to narrow down that differential. You can see how the LCH is actually quite aggressive appearing on the MR. So they were still worried that this was underlying tumor and ended up having a biopsy. So I'm going to move on. Candidate 2.
So I'm given with the frontal radiograph of knee joint with distal femur and proximal tibia visualized in a skeletally immature patient, and I can see generalized sclerosis of the distal femur metadiaphyseal region with a band-like, I can see a lucency running beneath the cortex and the sclerosis of the femur in the diaphyseal region, and rest epiphysis and tibia fibula appear normal. soft tissues appear normal to me. So, based on this sclerosis of the metadiaphyseal region, my differentials would be.
Before you get to differentials, can I stop you and just think about whether you can see any aggressive or non-aggressive features on the
So
clinical?
I am not able to differentiate whether this is a lucency beneath cortex or is this a periosteal reaction. So I would say it is a periosteal reaction and attribute towards the aggressive feature of the lesion.
Okay. Is there anything that you would like to know about this patient before you start to give a differential?
Perhaps lab parameters would help. Biochemical values of phosphate, calcium, or lead toxicity.
Okay. Why? What are you thinking?
Yeah. Based on the periosteal reaction, my differential was of an osteosarcoma first, but then I was thinking if at all it is a metabolic disease of lead toxicity or.
It's quite focal for metabolic cause, isn't it? It's not affecting the, say, tibial or fibula.
And then osteopetrosis, but
if I told you that this is the patient's brain imaging, would
so
you?
I see a fourth ventricular mass and then solid cystic lesion here, and is it neurofibromatosis?
No.
Some form of phacometal. No, the orbit is involved. I see a lesion of orbit cavernous sinus. I see a lesion in intraparenchymal basal ganglia too, and medullogerminoblastoma penio and NF tuberculosis.
Do you think that the lesion in the brain looks aggressive? How does that link to the lesion in the bone? If it were an adult, what would you be thinking?
Is it a lymphatic? So parietal bone lesion appear. If had it been an adult, I would have the temporoparietal lesion. I would have said it to be a glioblastoma.
So I think that this is a really nice case. Actually, Sam knows this case better than I do. I think the patient had a neuroblastoma, and the example is of a metastatic deposit in the distal femur. So thinking about metastases, I know in children it's not something that we jump to first, but having it there in the differential is really important. And then, thinking about other types of sarcomas, and you may be presented with, for example, lung metastases in a child and thinking backwards. So you may not be given the original pathology, as in this case. You may be given a secondary or a metastatic deposit. And actually for, that was a medulloblastoma? Sam?
Yeah, there was a medulloblastoma, and if you go back to the one slide before, posterior fossa tumors in kids. I know this can be in adults a bit different, but we are doing a pediatric talk. So posterior fossa tumors, it's hyperdense. In the fourth ventricle, the first thing you think of is medulloblastoma. Yes, you can think of other things like hemangioblastoma, but often, this is a non-contrast scan. You're thinking there'll be contrast enhancement with a bigger cystic component. The other things you think of is a pilocytic astrocytoma. Again, much larger cystic component. So, the others do have metastases down the CSF, so like neuromets, but then it's just an interesting case because take note of the timeline. So if you hadn't gotten that this was some sort of brain tumor, because I think it looks fairly aggressive, right? Because you've got your hydrocephalus there as well. And again, posterior fossa thingies, you would think brain tumors first. And then if you start to see that 2022, why have things changed? And things do look fairly dodgy, aggressive, with, cystic components, although I didn't give you the full slices. Then when you look at the post-contrast one, the bottom right-hand corner, it's a lot of enhancement. It involves the bone, it involves the brain, there's proptosis. It just all looks very aggressive. So you want to go down the route of, is this tumor progression? Is it going somewhere else? Of course, you can say, yes, it could be a neuroblastoma with everywhere metastases. But I think that if you ask the key question, was the 2019 scan the only scan, and what was the symptoms, then I think it would help you to get to the diagnosis a lot quicker. But again, this is, I mean, we are not giving the full picture, so a lot of it you have to do a lot of assumptions. Okay.
Thanks, Sam. Saving me again. So yeah, next. Candidate 1.
Okay. This is a left femur EB and lateral radiograph. I see there is the diffuse mousse eating infiltrating the medullary lesion involving the lower two half of the femur. There is Codman triangle process reaction. There is also I see some in the matrix in the medulla. There is denoting osteoid matrix, as well as soft tissue close to the bone. And this is young, this child. The cortex in the middle of this likely to be some medial surface breaching. So I dealing there is one zone of transition. I dealing with aggressive bony lesion. In this age group, I will going first with cerebral pathology, also sarcoma, owing sarcoma, and osteomyelitis. This is I will need to do CT cross imaging and contrast also MRI for further delineation. Okay, and MRI T2.